Hello, I'm Dr. Brett Ripley coming to you from Pikeville, Kentucky. We're here today to talk about the still technique. This is a technique I find particularly useful in the primary care setting. We're going to talk about where still technique came from, which originally it came from Dr. A.T. Still, but it was lost for a while, how it works, and then we're going to go through full body treatments on 4 different common family practice diseases: upper respiratory infection, lateral epicondylitis, asthma, low back pain with psoas syndrome, and then we're going to tie up. So this all started with Dr. A.T. Still, like much of osteopathy. One of the things about Dr. Still that we don't talk about much is when he started his first school, all he taught was anatomy. He did not teach manipulation, and he did not teach the people in the classes how to do manipulation. Picture going to school for a year or two with a guy who's the best manipulator in the region, perhaps in the nation, and he won't show you how he does it. You have to figure it out yourself. Well, that's how Dr. A.T. Still taught school. That's how HVLA became the dominant modality in osteopathy, because that's what the students figured out for themselves and then passed on. Well, what Dr. A.T. Still did, many of the teachers later came back and picked up. They'd go and sit with him while he practiced and learned how he did it. He also wrote about it later on in Philosophy and Mechanical Principles, though the detail is somewhat lacking. It takes a lot of imagination to make what he describes into a useful technique. We do still have a film of Dr. A.T. Still practicing. He is doing a lecture in Kirksville at an outdoor auditorium. He has a crowd in front of him that you'll see later in the film, and he has somebody he's practicing on. You're going to see where he places his hands. So his initial starting position, he places his monitoring fingers on the clavicle, and he goes through a range of motion. And he's going to talk now about what else you can treat with this technique. And I'm going to run through this one more time for you, so that you can pay close attention to where the hand is, where the lever arm is, and the motion he goes through. That's the still technique. Now he is also doing something you can't see, we believe, when he did this, which is apply pressure into the joint he's treating. And now he's going to carry on with the lecture, showing you the points he can treat this way. And he'll turn to his audience and start taking questions, and we'll leave him there. So Dr. A.T. Still did this technique, we believe. As I said, he didn't actually teach anybody how to do it. So how do we know about the still technique now, and why? Well, Dr. Van Buskirk, he was a PhD neuroanatomist at the time at the West Virginia School of Osteopathic Medicine. He did get his DO, and he currently practices in Florida as well as lecturing on the technique. He started reading A.T. Still's works, in particular the Philosophy and Mechanical Principles. He started reading the works of the folks who trained with A.T. Still as well, and they were more descriptive of the techniques. And he started experimenting to try to rediscover how A.T. Still treated patients. Now, if you read Philosophy and Mechanical Principles, it's clear he had more than one treatment technique, but this A.T. Still or still technique does seem to be one of the dominant ones. So why do I like the still technique? Well, I'm a family practice doctor. I see patients in 15, 20, and 10-minute blocks. I don't have time to take them into the treatment room, lay them down on the table, explain what I'm going to do, and do a full body treatment for most cases. Now, I do block two slots a day out to do that, but in most cases, I'm in 10 to 20-minute blocks. So this is a quick technique that I can do on my standard exam table. I don't need a special table or position to do it. It's non-threatening. So HVLA is the other very quick technique we have, but especially in the cervicals, people often don't like the motion you're going to do with HVLA. The other is it's effective for joints and fascia and muscle. So it's a very broad-based, useful technique. And how do you do the still technique? Well, the still technique is really quite easy to do if you know how to find the position of ease. So that's the first step. You choose the joint you're going to treat, You move it into its position of ease. You have to have a lever arm to move the joint with. That was the hand on the elbow in the picture of A.T. Still. You monitor the joint. That was the fingers over the clavicle in the picture of A.T. Still. You hold the joint in the position of ease. You compress into the joint. And this is one of the keys that was lost with the A.T. Still technique for many years. If you're moving the elbow as your axis to get to the clavicle, you can't compress into the shoulder and expect it to work. You have to picture and compress from the elbow to the clavicle, and you have to hold that through the whole range of motion as you move the joint to articulate the clavicle joint. That's true of any joint you're treating. You have to compress into the joint you're treating. That's your force vector. You use the force vector to move, as I said, and then you return it to neutral and you recheck. One of the very nice things about still technique is you can repeat it. If you don't get it all the first time, you do it again. So we're going to treat 4 different diseases and give examples of how I do this in the office. Except for the psoas spasm, I never spend more than 3 minutes treating a patient. We're going to talk about upper respiratory infection. We're going to talk about lateral epicondylitis. We're going to talk about asthma, and we're going to talk about psoas spasm and low back pain treatments. So when I think about how to treat a disease process with manipulation, I think about 3 different things. The first of which, what is the sympathetic referral to that area, to that disease process? In the cold, the sympathetic referral is the referral to the head and neck, which, depending on the book you like, is T1 to 4. Now, one of the unique things about the head and neck is that it travels along a fairly long nerve, the sympathetics, to get there. There are ganglion involved. So there are also predictable somatic dysfunctions at the mid-cervical ganglion. So if you take a look at this picture of the neck from the anterior, you can see the mid-cervical ganglion. It rests between C3 and C4 vertebra. As I said, there are predictable changes in that area as well. You also have to think about the parasympathetic referral. Parasympathetic referral to the head and neck comes through the vagus nerve, and it exits through the jugular foramen. Now, if you look at this anatomical picture, you're going to notice the capitis muscles and the rectus muscles lay in very close proximity to the jugular foramen, which is just medial to the styloid process. And these muscles are all activated when the parasympathetics are activated to an upper 2/3 of the body infection process. You also have to think about the lymphatic flow. That's the third of the things I think about with treating disease process. So the lymphatics to the head and neck pass through the thoracic outlet. And you can see on this picture just above the superior vena cava where the thoracics curve over the first rib and dive down into the thoracic outlet. So you want to treat, and you're primarily looking at the left first rib because that's the primary lymphatic flow to the head. So these are the 4 things we're going to treat. We're going to treat the OA to calm the parasympathetics. We're going to treat C3 to 4 to pick up the sympathetics at the mid-cervical ganglion. And there's a pretty predictable extended somatic dysfunction in that region. We're going to treat T1 to 4 for the primary sympathetic referral zone. And then we're going to treat the first rib to open up the lymphatics and help everything drain. So we're going to go to the tables now. So we've come to the tables. You're all sitting there with your partners. I'm going to demonstrate the techniques for a cold, and then the instructors are going to circulate through your tables and help you do them on each other. Our model today has allergies, but he doesn't actually have a cold. So he doesn't have the C3 dysfunction extended that's characteristic for a cold, but he does have OA dysfunction, he does have upper thoracic, and he's got an elevated left first rib. So we can show you how to actually treat those things. We're going to start with the OA, as it's easier with a cold when they're sitting up to start at the top than the bottom. And while we have a nice OMT table today, this is just as easy to do on a standard exam table. Your fingers are going to go on the posterior, right about the hairline. You want your monitoring fingertip between the occiput and C1. Your other hand, the activating force hand, goes on top of the head, and you're going to find the position of ease, the first technique, first step in still technique. This is also your somatic dysfunction diagnosis. So he is currently side bent left, extended, and rotated right. So now I have him in the position of ease. I wait a short period of time while his muscles relax. Now patients will fight you when you move them, so it's good to tell them to relax. The technique still works if their muscles are tight, so don't worry about that. But if they can relax, it'll go smoother and be more comfortable for them. So now I'm going to apply compressive force with my hand on the head. I will apply 3 to 5 pounds, which turns out to be just about when you feel it in your fingertip that you're monitoring with. So I compress, I say relax your head and just let it move. I'm going to reverse all the directions we had and go through a full range of motion and return him to vertical. So that's the OA. Now C3, 4, it's the same technique. You just move your monitoring finger down to between C3 and 4. In this case, you kind of expect it to be side bent and rotated, and he's side bent and rotated left. No flexion or extension in this one of any significant amount. Again, compress with your upper hand until you feel it in the joint. It's a little more pressure than the OA because you're going a little farther. Then your patient relaxes his neck and lets his head drop and move through a full range of motion to release it. Now I spoke about treating the first rib. You usually treat the left first rib because that's where the lymphatics go for the head. You're going to move over. Remember the monitoring finger, well, you monitor the first rib right over the clavicle. So I'm monitoring here. I'm also monitoring with my palm over the posterior rib head. I use his arm for my lever arm. I've never done it like AT Still does behind the back. That's more for the clavicle. The first rib usually balances out here somewhere. And in this case, he balances a little above vertical. So when I press, I'm pressing here, posterior attachment of the rib, and that's where I need to feel the pressure and maintain it. So I'm going to press down the elbow, but I'm gripping it so I can get it directed. There's a little torque in this too. I'm going to move it across his body. Now at this point it deviates and it'll go either up or down. I can't say it's consistent. Elevated rib goes up or down, depressed rib goes up or down. I usually go up first and I recheck it and his corrected. But if it hadn't, I'm going to do this without pressure, you would go across the body and you end up going down. Remember to keep your force into the joint when you do it. So it could be either one, and often I'll end up just doing both. Again, non-traumatic, it works well. Now I'll walk around the patient for this, but for filming purposes, let's have you swing your legs over to the other side of the table. So the last remaining part is the sympathetic referral zone, T1 to 4. The upper thoracics are treated. Now you'll notice that I'm putting my arms on his shoulders, and that's important to this technique. You're not putting your wrists on the shoulders, you're putting your arms on your shoulders. This is your lever arm. Through here, this is your compressive force right here. Your fingers are kept loose because they're monitoring. So I pick out the worst somatic dysfunction, and it's about T2, 3 for him. It is side bent right, rotated left, and it's a group curve. So I'm going to adjust a little to try to pick up most of the curve and see if I can get it all at once. Compressive force into my fingertip. That's my monitoring finger here. So I press till I feel the force there. I'm going to have you drop your head back as I move you. No, back. And reverse the directions. Okay, so we recheck. That one's pretty good. Still got one down at 4. So I only got a couple of them that time. We'll find our position of ease, wait for the muscles to relax, compress, and reverse them, and drop your head forward for this one. You notice how I'm using his head and his own motion to get my flexion and extension. And he has a C7 T1. It isn't technically sympathetic referral, but I think I would go ahead and get this one too. Drop your head forward some there. Okay, so as I move you, you're going to move your head back. So now we reverse our directions and go through a range of motion. Okay, and that is treatment for the common cold. You've addressed the parasympathetic, you've addressed the sympathetic here and here, and you've addressed the lymphatics. Treated an upper respiratory infection, and hopefully you can see how you can do that in 1 to 2 minutes. Now we're going to talk about the next disease process we've got. That's lateral epicondylitis. It's a very common thing in a family practice clinic. And of course you can inject it. You can use the NitroDur patch technique. It's in UpToDate if you want to look it up. Or you can do manipulation. And in fact, as a family doc, I don't mind doing all three, whatever it takes to get my patients better. Now, lateral epicondylitis is a pretty simple problem. It is all mechanical. There is no sympathetic component, there's no parasympathetic component, and while lymphatics might be part of it, they are not a big part of it. There's rarely all that much swelling or edema in lateral epicondylitis. The things that are involved are the attachments of the extensor muscle mass, which move into the lateral epicondyle. So if you're looking at your lateral epicondyle, your extensor muscle mass here, that's where the tightness is. That's where you have to treat to relieve the tension on the attachment of the lateral to the lateral epicondyle. You've also got the radial head, and compression of the radial head or somatic dysfunction is a part of this. You've also got the olecranon and its movements. You have to make sure that's normalized. And that's what I do manipulation-wise to help this problem. We're going to go to the tables now, and we'll have everybody try to treat it. We will try to treat the radial head, the olecranon, the extensor muscle mass. So this is using still technique in a myofascial way. And we'll treat the attachments to the lateral epicondyle. So now hopefully you're all at your tables again with your partner. This one is the lateral epicondylitis treatment. And remember, this is primarily a mechanical system. We're going to have our hands pretty much on the elbow for the whole set of treatments. I'll talk to you about where I'm moving my fingers, but there aren't going to be big motions in the hands. Now remember, you have to control the whole forearm. I like to do the handshake with the 2 fingers down the arm like this, because it gives me good control of rotation, AB and AD duction, flexion and extension. Occasionally I'll switch over and just hold the wrist, especially if they have sore carpal tunnel or some other hand dysfunction that I'm not treating at the time. So you're going to start. So lateral epicondylitis. Pain is right here, lateral epicondyle. You should be able to elicit it by pressing, most commonly between the radial head and the lateral epicondyle, but anywhere along this arc should be the most painful position. You're also going to look into the extensor muscle mass, which is through here, and find the tight, taut, ticklish, or tender bands. They're usually a muscle band that'll jump out from under your finger when you're moving through it. You're also going to check for olecranon motion. And it ought to drop nice and solid into the olecranon fossa. She hits her bony restriction here, but if you push down, it kind of scoots along into the fossa. So she has radial head dysfunction. She has tight bands in her muscle mass. She's got an olecranon dysfunction. And then we're going to treat the attachments here. I'm going to start with the olecranon, and that's what I usually do in practice. So I'm going to switch my hand, because this is almost a straight flexion extension. These fingers are monitoring the olecranon right down here. This one's nice because the pressure is right along the long bone, just where you want to put it. So you just press down, come up, find the position of ease, do your pressure, and straighten it out. Now maintain your pressure. That's where people forget with this one. They'll stop pressing halfway down and it doesn't work. Recheck, of course. We got about 2/3 of it. So we're going to do it again. Get a little more precise positioning. Go ahead and straighten it out, maintaining the pressure. There it popped real nice into the olecranon fossa. So there it is, right where you want it. Radial head, I'm back to my handshake grip here. I've moved my thumb over for monitoring, right over the radial head. She has good supination and pronation. She has good, when the joint widens, when you compress the joint, she gets jammed up. So we're going to bring her into flexion again, because that's where the muscles relax. We're going to bring her into a distraction of the radial head, because that's where the muscles relax, and find the right point. Now this compression on this is tricky because you have to compress the radial head while you're distracting it. So it's kind of a interesting dance there, but if you get it right, and you bring it down, and you're going to, of course, go into compression with the head as you do it, and you recheck. Yep, and she has gained, she has a nice soft barrier now when we go thumbward. So we've got the radial head. Now we find our muscle mass, and remember that the still technique works for muscle and fascia as well as for bony joints. You usually try to find the worst spot, because if you treat that, all the ones around it will go away. Her worst spot is right here in her extensor muscle mass. You may see her making faces on this one, because it does hurt when you find the worst or most tender point. So I'm going to find the point of ease. You notice I'm pretty much curling around that muscle, just like you would with counterstrain. And you're going to do your compression, again, into the muscle, not into the elbow, which is where you're going to tend to want to do it. Keep focused on that muscle and move it down through the range of motion. We got about half that band. There's another one right underneath it. So we'll move up to the next one. And you will end up doing the muscle typically 4 or 5 times with variations of how much flexion and extension in the hand and flexion and extension at the elbow. And then little bits of rotation will get you right at that spot. Again, you always make sure you pressure and you always make sure you reverse. Try one more in here. She had a good one right over here too. Those are all going away, but she's got a very deep one there. And that got all the surface muscles, and it got everything that attaches here. She has some other stuff in her flexor muscles, but that doesn't apply. That's for medial epicondylitis. We treat the flexors. So we've treated the olecranon, we've treated the radial head, we've treated the extensor muscle mass. Now we're going to get that tender point, the worst spot. So you're going to find the spot where the pain was the worst, right on the head. Now this motion is often different. It's not always a straight flexion extension. There's a lot more of the pronation supination to it. So you kind of fuss around until you find that point of relaxation. She's going to shift out this way and go right about there. This is where it's nice to be practiced at finding your point of ease. So I'm going to compress into it and do the range of motion. And that worked pretty well. And so that's the treatment for lateral epicondylitis. We're going to now distribute ourselves out at the tables and make sure you all get a chance to try it. We've treated an upper respiratory infection in less than 2 minutes. We treated the lateral epicondyle, which does take more like 5 minutes to treat. It's still pretty quick, but you'll often have to treat multiple trigger points in the lateral and the extensor muscle mass, and that can take a little bit of time to localize them all and treat them. Now we want to talk about one of the most common problems in primary care, which is asthma. And asthma exacerbations are one of the most common things I treat, especially in children, but adults, and this applies to COPD as well, because they have a spasmodic component to COPD. So you want to think like we think about disease processes. What is the sympathetic referral for asthma? So asthma comes out to T1 to 5. It comes through the chain ganglion, sympathetic chain ganglion, and it moves through the hilum of the lung into the lungs. You can see a good picture of the sympathetic chain ganglion here, somewhat enhanced with yellow dye. Remember that somatic dysfunction in all the respiratory muscles is relevant in this as well. So you're not just going to treat the sympathetic T1 to 5, but if there's a problem down at T8 or T9 where the diaphragm attaches, you'll want to treat that. If there's a problem in the ribs, you'll want to treat that. What is the parasympathetic referral for asthma symptoms? Now it does come down out of the jugular foramen along the vagus, just like it did for the upper respiratory. Doesn't jump off on the petrosal nerves, it follows the vagus down into the chest cavity, and the lungs are innervated that way. And then the lymphatic flow, which starts to get a little more complicated now because the diaphragm and the cisterna chyli are involved, as well as the left-sided and the right-sided thoracic outlet. So you can see the lymphatics flowing up along the bodies of the vertebra through the thoracics. At the bottom of this picture, you can see the cisterna chyli. The crura of the diaphragm would cross over on that, giving your pumping. And then, of course, the negative interthoracic pressure is one of the biggest drivers of lymphatic flow. Up to 30% of the flow in the lymphatics is due to the negative interthoracic pressure. So if the ribs aren't moving right, if the diaphragm isn't moving right, you can't generate your negative pressure and you get decreased lymphatic flow. So we're going to go to the table now. We're going to redo the OA treatment because it's good to practice that one. You use it a lot. We're going to treat T1 to 5, which we'll do just like we did T1 to 4 previously. Then we're going to move into the thoracics and ribs, and I'll show you how to treat the lower thoracic vertebra and the ribs. And of course, we'll do a diaphragm treatment, and I'll have to admit I don't know a still technique for the diaphragm, so we're going to do a myofascial diaphragm treatment. It's the same one I use on my hospital patients. So our next disease we're going to use as an example is asthma, which is a classic chronic disease involving the lungs and the rib cage. Of course, you're going to think about the sympathetic referral zone, traditionally T1 to 5. You're going to think about the parasympathetic referral zone. That's the OA, and we're going to treat it the same way we did last time. We've just got a little different camera angle. You have to pick up all the ribs and all the thoracics down even into the upper lumbars. The lowest crura of the diaphragm attaches at L4. So you may have to go as far down as that to get all the somatic dysfunctions that are affecting breathing. We'll get the lymphatics the same way by treating the rib cage, and then we're going to do a myofascial release of the diaphragm because I don't have a still technique diaphragm release that I like to do. So the first thing, we're going to address the parasympathetics. Remember that the vagus nerve carries parasympathetics to the upper 2/3 of the body. Remember to monitor between the OA and C1. Your control hand is up on top of the head. You get your side bending and rotation component, a little bit of flexion or extension, pressure into your monitoring finger, drop your head down, and you just move through a full range of motion. Okay, so now we've addressed, that's the parasympathetics. If C2 is a significant problem, you might want to pick that up too. And remember, that's primarily rotational. So you would pick C2 up like that. T1 to 5, again, arms on the shoulders, fingers on the somatic dysfunction. We've already fixed him once, so we're going to go down to T5 where he's still got a little residual somatic dysfunction. Side bent right, rotated right, that's a good one to get. So we can compress into it in reverse directions. Now, what I didn't show you last time is you can do the first ribs this way too. Your compression is going to have an element of rotation inwards, but in the interest of not moving your hands 10 different times, you can pick up the first ribs, you can do both of them. Just moving through range of motion, and you're going to do the whole top part of the rib cage just this way. Find the dysfunction, lean. Remember to compress into the rib head, not into the vertebra. Compress and through the range of motion. Now, somewhere around T5, it gets awful hard unless your hands are a lot bigger than mine to get to the dysfunction to monitor it. So at T5 is when I change techniques. We move the arm up across the body. Now this gives you a good handle. If you're working on a female, it protects them from having you grab their breasts while you're moving them around to treat their somatic dysfunction. When I'm on a table like this, it's harder. This one actually works better on an exam style table where it's easy access to all sides. But on a regular OMT table, I end up putting my knee up on the table. I'm going to put my shoulder here, and my hand here, and those are my pressure points for compression and controlling the body motion. And it gives you very good control of how he's going to move. So I'm just going to pick a couple examples to treat here. He's got a pretty good group curve along there. I'm going to monitor between the vertebra on the group curve. He's going to side bend, rotate, flex. Got to get that compression, and I'm shooting here with my compression, and we reverse him. And we're going to move down. Remember I said you can treat way down. This is my technique for the lumbosacral junction if they're sitting up when I start on it. So again, you get your diagnosis. He's flexed, rotated, and side bent left. Compress all the way down, so pretty good pressure now. Drop your head back. There you go. And you can still use the head for flexion extension, even all the way down to the lumbars. For a rib, you just come out onto the rib head for your monitoring, and remember to press into there. They tend to be a little bit more translation in the rib cage than they are in the vertebra. So a rib treatment might look like this. So we've addressed the thoracics, we've addressed the ribs and the breathing mechanism, picking up the lymphatics along the way. The diaphragm is the last thing left to treat. I mean, you always want to treat the asthma with diaphragm. It will go into spasm with an acute exacerbation. There is a still technique for the diaphragm. I have to admit it doesn't work very well in my hands, so I tend to do a myofascial unwinding, the same one I do in the hospital. For that, you have an anterior hand. It's at the xiphoid process in the midline where it attaches to the diaphragm. The posterior hand is a little lower down. I usually try to cover something from L2-3 up to about T10. You're going to find the tension between your hands, so there's going to be a rotation component. So you rotate, and you often end up compressing one side or the other. So he's going to end up rotating like this and compressing into his diaphragm. It's myofascial. It is a direct myofascial, so I'm going into the dysfunction. So he's actually somatic dysfunction right of the diaphragm, which is the side that moves freely, or restricted left. And either naming is okay. And you just wait for it to release as he breathes, follow it as it goes, so the rotation's coming out for him quicker than the compression on the left. But there it goes. They will often take a spontaneous deep breath as you release, but not always. And that's treatment for asthma. We've addressed the parasympathetics, we've addressed the sympathetics, we've addressed the rib cage both for breathing and for lymphatics, and we've addressed the diaphragm. So we've treated three things so far, common disease processes. In the classroom, you've been taught how to treat low back pain. So now we're going to do something a little more familiar with your OPP knowledge. We're going to talk about the psoas syndrome. So you have to think about the psoas muscle and where it runs and why it causes pain in its particular distribution. You want to think about where the psoas muscle starts, which is from T10 to L2, and where it inserts, which is into the lesser trochanter. This gives you your characteristic pain of the psoas syndrome, which is, it originates in the mid-back. It's most intense over the belly of the psoas, here right above the iliac crest, but it often radiates into the gluteal fold, where the attachment of the psoas is to the lesser trochanter. It is primarily a mechanical problem, though it can have lymphatic and sympathetic and parasympathetic involvements. So what's somatic dysfunction? There is classically, and this is a board's question fairly often, a somatic dysfunction that triggers psoas spasm. And it's a non-neutral in the T10 to L2 region. If I was answering on the boards, I would say T10. But in T10 to L2 if you're in the real office. So we're going to treat the psoas muscle. We're going to treat the thoracolumbar junction because we've got a non-neutral in there somewhere. And then we'll move on to the pelvis and the sacrum, which is kind of nice because you can, with the same positioning of the patient, very quickly switch your treatment from the sacrum to the innominate to the pubic symphysis to the psoas muscle. And we'll go to the tables now. The last treatment we're going to do, and you should be at the tables again at this point to watch and then do it yourselves, is going to be for an iliopsoas spasm with sacral and pelvic dysfunction. We have our person laying down. You can do this on a regular exam table. They all have pull-out feet where you can do it. So you can still do this without moving to a fancy OMT table if you don't have one available. So she's going to have a left psoas spasm. She happens to have a posteriorly rotated right innominate with an upslipped pubic symphysis. And I think her sacrum is going to follow once I fix this, but we'll recheck her sacrum before we call this done. Now, all these treatments are remarkably similar and look very much the same. It's where you're monitoring, it's where your force vector is going that makes them different. They're in a psoas spasm. So the first thing we want to do is relieve the pain from the spasm. So we're going to pick her legs up. We're treating a left psoas spasm. So we're going to rotate her. Now this position is going to look awful familiar from counterstrain because it's going to be about the same position she would get for counterstrain. And it's right there. I often end up waiting a while to let this muscle relax. It's a big muscle. It doesn't like things to go fast. You're also going to go very slowly when you do your range of motion. So I compress into the hand and the psoas muscle. I feel the pressure in my finger monitoring the mid-psoas. I move back to midline, I derotate, and I'm going to come down. Now one of the tricks is her feet are going to hit the table, and you don't want them to, so you have to maintain pressure with your shoulder while you scoop her legs out straight. It's not uncommon, even with a muscle, to get an articulation as you move through the range of motion. And you actually did pop in there as it released. So I'm going to pick up her pelvis now. So now my monitoring hand goes to the left innominate. I usually put, I'll show this on the right, I put a hand on the back, I use my palm on the ASIS. I can feel the whole motion of the innominate on both sides of the axis. So I'm going to monitor here, bring her legs up. This one's more of a straight line dysfunction. I'm not getting much of the rotation in this one at all. So I find the point of ease. Now I'm going to shoot towards the innominate sacral junction. That's where my pressure goes. That's where my posterior fingertip is. Pressure into it to where I can feel it. Not much rotation, so there's not much rotation coming out of it. So come down, remember that fancy little scoop. Okay. Then you recheck. So we've leveled those out. I'm going to check her pubic symphysis. See if we got that too. Still a little bit of a compression. Now to articulate the pubic symphysis, and I'll have to admit, I almost never monitor the pubic symphysis directly. There are sensitive parts of the body in that area, and people don't like you sticking your hand down there. So I'll monitor it from the PSIS. And I'll go side to side, so she's more relaxed. Now I usually end up doing almost a straight side to side motion with the pubic symphysis. Sometimes with a rotational component as well. So compress into the pubic symphysis, articulate it across, and I end up dropping the legs down and straighten her out. Check your innominates again to make sure you didn't mess anything up. That one's pretty level. I said I'd recheck the sacrum, and I'll recheck her just laying here. I can slide my hand under and pick up the cranial motion of the sacrum or the flexion and extension from breathing. She's moving right on the midline, so we're not going to have to treat the sacrum, but you would monitor on the sacrum and do a similar motion. Find the point of ease with all your degrees of freedom. Now the last thing to do with the psoas spasm is to get that T10 to L2 non-neutral dysfunction. The nice thing is, I mean, we could sit her up, We could do like we did previously with the asthma case. But with the legs moving up and down, you can also shoot up as high as T10 very easily. So instead of moving her around and making her change position, I'm going to find her non-neutral dysfunction. She is up at T10. To get compression and to do this right, you're going to be a little more extended than you were. You're going to rotate and side bend. So she is, remember you name from the top down, so even though it looks like she's rotated right, the dysfunction name is rotated left. If I was moving her upper body, I would move her left. Compress. Now there's a lot of torque in this to get the pressure up into the spine. So you'll see me going like this to get that torque into my fingertips. So then I reverse the rotation and side bending, bring her down, straighten her out. That's worked pretty well. So that is the treatment for psoas spasm. Treat the psoas first, it hurts the worst. I could do the sacrum or the pelvis, either one first. In her case, her sacrum was not a significant issue. So we treated her nominants, we treated her pubic symphysis. Don't forget the pubic symphysis, everybody does. And then you have to pick up that non-neutral and the T10 to L2 to make it stay away. So everybody at the tables, get your partner down and we'll go through the room and try this with you. Now we've treated an actual traditional osteopathic disease process as well. Remember the summary of still technique. Find the restriction, find a lever, find the point of ease, compress to the joint or dysfunction you're treating, that's the key. Move it through a range of motion and retest. These are the folks who helped me out. You'll notice Michelle Ng and my father, David Ripley, were instrumental in the photography. And A.T. Still. He had a dream of what an osteopath could be. I would maintain that family practice is as close as we can get to that these days. That's why I'm a family doc. But this is up to you to think about. How are we doing? How's the philosophy doing? You, as our younger generation, are going to find where we go next. Good luck.